So I'm Dr. Chris Sear. I'm a nephrologist and the Chief Medical Officer for Telecare, and today I'm going to talk about our virtual geriatric care models that we've been implementing. So I'd like to acknowledge the traditional owners of the lands on which we meet and the lands on which a lot of this work is done, so in particular the lands of Yane, Gambia, Seymour, and Mackay Hospital and Health Service, and I'd like to pay respects to their leaders past and present. So it's no surprise, or it's no secret that geriatricians are in high demand. And I think we'd be a little bit surprised to know that there's only about 1,000 geriatricians practicing nationally, and around 10% of them, only 10% or 11% practice outside major metropolitan cities. So this means that the vast majority of geriatricians are in cities, and access to geriatricians in rural and remote areas is very low. The risks of not having access to geriatric care for the aged population include delays to critical interventions and potentially increased hospitalizations, some of which may be potentially avoidable. And additionally, I think this is a problem in all hospitals. The hospitals are full. We've got patients that are sitting in hospital that could potentially be managed at home, or they're awaiting nursing home placement, for example. But we really do have issues with bed capacity in hospitals. And so these two models that I wanted to talk about were designed really to help address these problems. And importantly, they came out of the hospitals or the health network approaching telecare with a problem, and us co-designing a solution together to meet this particular problem. And I'll go into them in a little bit more detail, but a little bit more about Telecare and who we are. So Telecare is a specialist telehealth company. We're probably one of the largest specialist telehealth companies in Australia. We have over 300 different specialists covering over 30 specialties. We do over 40,000 consultations a year. And importantly, we have a lot of partnerships with public hospitals and hospital networks as well, both in the inpatient and outpatient space, where we provide virtual care. We also do some remote reporting and have a development team that develops software that really helps us to implement these models of care that we co-design with our partners. So we're ISO accredited and have been selected as the only private provider to help develop the national care standards, virtual care standards, apologies. Okay, so the first model that I'd like to talk about is a virtual geriatric in-reach model for rural residential aged care facilities. And so I think we're probably all aware that some patients in nursing homes do struggle to have access to a GP. Traditionally, what happens is patients will have a usual GP, and then eventually they'll deteriorate and they'll need to go into care. And sometimes these GPs will follow them and visit them in hospital, in the nursing homes, but oftentimes, because the GPs are quite busy and because of financial reasons or whatever, the GPs may not want to sort of visit them in the nursing home. So they're often stuck in these facilities without a regular GP. And I think this was a problem. This is especially a problem in rural settings where GPs are very busy and very limited anyway. And so Hume Hospital and Health Service reached out to us with a potential solution that they wanted to look into to see whether they could meet this demand or meet this gap. And what they proposed was mainly using nurse practitioners to help to look after these patients. So they would see patients in person, and they would refer to Telecare's specialists, mainly geriatricians, and facilitate a video consultation together, and with a shared care model, look after these patients. And so the idea would be to proactively manage their medical conditions, review their medications, and potentially avoid hospital transfers, and hopefully improve patient outcomes. So these in-reach nurse practitioners, or sometimes the patient's GPs, depending on the individual patient, would perform an initial on-site or in-person assessment of these residents. And then, as required, they would refer to our specialist geriatricians or ACHSM and conduct video consultations. And our specialists would have access to medical records and investigations before the consultation. There'd be a shared decision-making process which would often involve local staff and families, and then the information would be disseminated. We also developed a web portal which helped for secure data transfer of medical records. So moving briefly to the results, I think it's clear that most staff that were surveyed did agree that without this service, these patients would not have had access to these subspecialties of geriatric care. And some quotes: I think it's a great service. We would not be able to provide this level of care for our clients. And this is a bit small here, but I'll read this quote. I work as a nurse practitioner for the Rural InReach program. We started using the telecare geriatrician model due to difficulties in accessing geriatrician reviews in a timely manner. The service has been amazing, and we've been able to achieve 100% annual geriatrician review in some of the facilities. Doctor is a fantastic clinician and very thorough and knowledgeable. The administrative support by telecare has been exemplary. I highly recommend this service. So that's the local nurse practitioner. So we've facilitated over 100 consultations since September, and it's estimated that we probably have saved at least 10 patients from deteriorating or being hospitalised. So there were some challenges. I think the local nursing staff were a bit sort of set in their ways, and it did take a few sessions for everyone to become comfortable with the whole setup. As you can imagine, there are going to be technical issues with setting up a video call, but that was solved by using a dedicated portable device. And there were initially some issues with document transfer, but we did build a portal which allowed for secure document transfer to get around this. And so I think in terms of next steps, it's been proven to be a model that's quite workable and scalable. So the next steps will be, how do we implement this in other areas? And the other idea that's come about is potentially having some multidisciplinary meetings or MDTs for upskilling and better case discussion and case management. The second model I wanted to talk about is a different model. It's a virtual geriatrician which is embedded in a hospital in the home gen rehab model in regional Queensland. So similarly, there is a geriatric shortage in Queensland, and similarly they have very poor access to geriatricians and high bed occupancy. And so we're dealing with similar problems here. So this solution that we developed with the hospitals reached out to us to work together to solve, involves embedding a remote geriatrician into an existing hospital in the home model. So you have patients that are on the ward that could potentially be looked after in their own home by nursing staff, have home visits by occupational therapists and physiotherapists, but they do require some medical supervision by a geriatrician, and they just didn't have that local geriatrics workforce to help coordinate everyone and bring this program all together. And so they reached out to us to see whether we could use one of our geriatricians to really hold this program together. And this, for a bit of background, Telecare already does a lot of work with Mackay. They outsource about 12 different subspecialties to Telecare's specialists in the outpatient space to provide consultations, and we also provide virtual inpatient consultations already. So there's already an existing relationship with Mackay Hospital, and this was just an add-on to a model that they were keen to do. So as I said, we have inpatients that could potentially be looked after at home, and with the geriatrician now supervising them, we were able to launch this program. In addition to the consultations which happened at the patient's patient's home. There was also a weekly multidisciplinary meeting which involved local doctors or local registrars and allied health professionals, which again allowed for upskilling and training. So this is a brief slide about how this was all developed over this year. There was obviously a co-design process and some tech that we needed to build, so a workflow solution which was able to coordinate all the appointments. Our specialists also have direct access to the electronic medical record, which really made things a lot smoother for data communication. So the main benefit of this program is really we're able to free up inpatient beds by transferring them to care at home. And so we facilitated about 200 home visits, held 40 geriatric consultations and held multiple case conferences. And we estimate that even in this very short period of time that this service has started, we've been able to free up about 600 hospital bed days. The graph's a bit hard to interpret, but the uptake is improving, but obviously could still, there's obviously a lot of room for improvement. So in terms of some feedback from our nurses and our allied health, 100% of staff reported good logistics, and 86% agreed that without this service the patients wouldn't have access to treatment at home. So really the virtual geriatrician model was vital in making the whole program run. And in terms of training for our allied health and medical registrars who otherwise wouldn't have access to a geriatrician in their training, most of them agreed that they learned from observing and collaborating. So I think that's very important for training and also career development. So just as a case study as to what something might look like, we have an 80-year-old lady who had a fall and has a fractured wrist, which is managed without an operation, but because she's below her functional level, she's home alone, is a bit concerned about her just going straight home without any support. But she was assessed by this program, this GEM Rehab Hip Hospital in the Home program. The orthopedic team provided the bed card, and then the GEM RHIT provided the nursing staff, the physio, the occupational therapy, and the geriatric support. So this is a bit small, but so again, day one, patient goes to the ED, gets assessed, referred to the program, accepted, and then they're sent home on day two. And then on day three, we have a nurse visit to provide care. On day four, we have an occupational therapist and a physio assessment. That's day 4 and 5. And then on day 6, we have the geriatrician performing the patient medical review. There's a multidisciplinary meeting with the patient, the daughter, the nurse. They talk about various things, medication reconciliation, they talk about analgesia, fracture clinic expectations, how long to keep the sling on, and eventual discharge from the program. And so this would be a very typical sort of patient that we would see that would potentially, keep them out of hospital for a week under this model. So there certainly are some challenges. One challenge would be how do we identify patients for this model? We're a bit reliant on teams referring to the model, whereas if we develop clear criteria and we have the workforce to do so, potentially we can proactively identify suitable patients and pull them into the model and hopefully improve uptake. There are, of course, going to be some technological issues with video and internet connectivity, as you can expect when doing consultations in the patient home. There's a bit of a diagnostic scheduling coordination issue, especially if patients need scans and tests, and how that can sometimes conflict with scheduled consultation times. And there are, of course, a lot of administrative work that goes into coordinating all of this. But I think even though this is a small and early project, I think we've been able to show that it does have the potential to open up inpatient bed space and alleviate pressure on inpatient wards. So I'm really excited to see how this is going to grow, whether it can be scalable expand into other hospitals and other hospital networks. Thanks.